Okay, so good morning everyone. Today we continue our journal club activities. Today Dr. Dalal will present us a very interesting topic about aortitis, their imaging or spectrum of imaging findings.
لا والله بس التقليد من هنا. Good morning, my teacher. Good morning, my colleague. Today I will present topic about aortitis. This is very noisy. Aortitis is a general term. Called a pathological term referring to infectious and non-infectious causes. Regardless of the underlying cause, it causes inflammation of the wall. Non-infectious causes is more common. Before I will start my topic, I will just talk briefly about some important points to understand the topic. First, we see the anatomy of the aorta, starting by aortic arch. Okay. The aortic arch, you know how the lumen is regular. The thickness of the wall is not more than 3 mm. And as we see, when it bifurcates, it gives ascending aorta and descending aorta. Just focus on the diameter of the ascending and descending. The ascending is more larger than the descending aorta. Again, the lumen is regular, no any ulceration. The wall is regular and thin, no any thickening surrounding it. There is no any surrounding soft tissue thickening around the vessels. No any perivascular air, no any surrounding, no any mass, no any narrowing or aneurysmal dilatation. As we can see, we can say that the diameter is variable according to the location, according to age and sex of the patient. But generally, we can say that the ascending aorta is aneurysmal when it exceeds 4 mm. 4 cm. And the descending is aneurysmal when it exceeds 3 cm. And the abdominal aorta is aneurysmal when it exceeds 5 cm. So we can just remember it 5, 4, 3. 5 abdominal, 4 ascending, 3 descending. Let's start our lecture with the topic non-infectious aortitis. We said that aortitis means inflammation of the wall, regardless of the underlying cause. So we can broadly classify the causes into non-infectious and infectious. Non-infectious is more common than infectious causes. The non-infectious causes can we just classify it as large vessel disease, medium-sized vessel, or small vessel disease. Also subclassified into idiopathic causes, radiation-induced causes. Of course, infectious causes, you know, that's caused by bacterial, viral, TB, fungal. The most important topic today is Takayasu Arteritis. It is large vessel disease, so mainly affect aorta and its branches. From the name, we said arthritis, so it's the inflammation of the wall. It causes many things to the aorta because it's diseased wall. So we can expect narrowing, thrombosis, occlusion. As we can see here, conventional angiography for the abdominal aorta. We can see that infrarenal abdominal aorta is narrow, with narrowing of the left common iliac artery and occlusion of right common iliac artery. Here, MR angio, same finding, but the MR is better than conventional angio. Why? You see that we can see the changes distal to the narrowing, not like in conventional angio. Distal to the narrowing, we can see the changes also. So Takayasu cause occlusion or thrombosis or narrowing of the lumen of the aorta according to the degree of inflammation of the wall. Here, I just want to compare the normal and the abnormal. As we said that the normal is regular, thin wall, and here we can see that the Takayasu affect both ascending and descending aorta to cause thickening of the wall, concentric thickening, and cause ulceration of the descending aorta. So if we want to compare which is most important, conventional angio or CT angio and MR angio, as an initial evaluation for diseases of the aorta, it's of course CT angio and MR angio. Why? Simply conventional angio invasive with radiation more than CT. Conventional angio not give us information about the wall of the aorta, unlike CT and MR give us information about the wall of the aorta. And of course CT and CT angio less radiation than the conventional angio. Any abnormality in the wall like calcification, mural thrombosis, gas, we can detect it in CT angio, not could be detected by conventional angio. As we can see, this is the MR of the patient. We can see also thickening of the aortic arch branches, which is left common carotid and left subclavian artery, and the arch, of course. So the cut point for saying that the thickness of the aorta is abnormal is 3 millim, more than 3 millim. And you can see that in MR we can detect the edema of the wall to know this is active disease or not by different sequences like STAIR, which is highly fluid sensitive sequence, and this is another MR angio to see how can the degree of affection of the aorta could cause cut point narrowing or occlusion of the abdominal aorta. So Takayasu is mainly large vessel disease affection. Another important entity is giant cell arteritis. Giant cell arteritis, it is of course chronic vasculitis. The important is it is mainly affects superficial cranial arteries, not the aorta. Aorta affected only 15% of the patient. As we said in Takayasu, I forget to say that it affects mainly young women. But here, giant cell arteritis rarely seen before 50 years. So it is not disease of a young people, and mainly affect superficial cranial arteries like external carotid branches, like vertebral arteries, can also affect other arteries like aorta and mesenteric arteries. The most important thing is the location of the affection. Giant cell arteritis mostly affect the ascending aorta. So in Takayasu mostly affect the abdominal aorta, then descending aorta. Here, giant cell arteritis mostly affect ascending aorta and extend to the arch, and could cause affection to the descending. you see that it is not as specific to say thickening of the wall. We see thickening of the wall in Takayasu, and here we can see also concentric thickening of the wall of ascending and descending. But the important thing is the distribution, the age of the patient, the history, the association of the features. In Takayasu, we said abdominal. Here we say ascending aorta. If we take the history and know that the patient has history of cranial symptoms referred to the cranial arteries, we can think of giant cell arteritis. Another example of CT, MR, CT angio. Here we can also see the thickening of the arch of the aorta. And here also we can see the thickening of the descending aorta. Also gradient echo MR showing the thickening of the aorta. And we said that many sequences can show us the edema of the wall, which indicate activity of the disease, like Bacet T2 MR, showing us that the wall highlighted after Bacet T2, so it indicates edema of the wall and activity of the disease. Another entity, which is non-infectious causes of aortitis, is Behcet. Behcet disease, of course, it's a chronic lapsing systemic disease of unknown etiology. It causes mucocutaneous ulcers and affection of large vessels, mainly the aorta. Some important point that Behcet causes saccular aneurysm, not fusiform, because in Takayasu and giant cell we see it as fusiform. Behcet can cause fusiform, but it may cause pseudo or saccular aneurysm. So here we can see CT angio, saccular aneurysm, causing pressure on the true lumen of the abdominal aorta and thickening of the wall. This is axial and this is the sagittal. We can see the saccular aneurysm and narrowing of the wall.
This is not sagittal, this is MYP coronal. Maximum intensity projection coronal reconstruction.
And this is conventional angio, showing us the aneurysm and the narrowing of the wall. Some entity called idiopathic aortitis, it is asymptomatic, not discovered only by pathologists after surgery for aneurysm. So the pathologist said that there is aortitis in the specimen of aneurysm, and of course it also causes thickening of the wall of the aorta. They note that the patient who has this aneurysm and take surgery, if don't take corticosteroid after surgery, he will develop another aneurysm. So maybe the aortitis is the cause. This is normal abdominal aorta. Its diameter is not more than 2 cm, but if aneurysm to be diagnosed should be more than 3 cm. Regular wall. No any ulceration, no any surrounding soft tissue thickening, no any perivascular gas, and no any wall thickening. Just to see the normal. Another entity called inflammatory aortic aneurysm. From the name, it is inflammation causing aneurysm of the aorta. The important thing it causes peri-aneurysmal soft tissue or dense fibrosis. And the other point important that it spares the posterior wall. So the inflammatory aortic aneurysm has two important things. It is aneurysm caused by inflammation, but it is accompanied by perianeurysmal fibrosis that spare the posterior wall of the aorta. You can see the irregularity here, some irregularity of the wall, and here you can see in sagittal CT the fusiform aneurysmal dilatation with the soft tissue thickening surrounding the aorta.
This is specific for the inflammatory.
Yes, but we shall progress to another subject that may also cause thickening, but in a different way. But this is a good point to see that it causes thickening and perianeurysmal soft tissue fibrosis and sparing the posterior wall. By giving contrast, there will be rapid opacification of the lumen, then late enhancement of the soft tissue mass. Here also CT showing aneurysm of the abdominal aorta with calcification of the wall, and you can see the soft tissue surrounding the aorta sparing the posterior wall. And if this is PET CT, and this is called non-fused. This is fused. This is I don't know.
This is just the PET image.
Yes,
And fuse it
and
with the
fuse it
CT.
with CT called fused PET CT.
PET CT. This is
Yes.
the PET with the CT over
Yes.
each other.
So the fused image, PET CT, showing uptake of the wall of the aorta, and before it we can see the dilatation of the both ureters. So it can cause mass effect on the surrounding tissue, this mass. Another entity, you may face it in the daily work, which is retroperitoneal fibrosis. We know that it causes mass-like fibrosis, mainly in the abdominal aorta. It is caused idiopathic, but some suggest that an exaggerated inflammation to atheroma in a diseased atherosclerotic aorta could be the initial cause for the fibrosis, mainly occur at the bifurcation of the aorta, in the abdominal aorta, and it ascend to the retroperitoneum to cause mass effect on the surrounding, mainly the ureter. It can cause fistula to the sigmoid, causing bleeding.
What kind of mass effect to the ureter?
Pressure effect.
يعني obstruction?
Yes.
Push
It
laterally,
causes just
push
displacement. No, just displacement.
It causes the ureters to deviate towards the midline.
Yes, displacement to the midline.
Displacement يعني lateral. Mass effect يعني pushing. It is not mass effect, it's pulling.
Okay.
Okay, that's typical for retroperitoneal fibrosis.
Yes.
You see the ureters deviates medially
Yes, yes.
instead of laterally. And it
below
is not
elbow.
always idiopathic. It has a lot of suggested causes.
Yes,
Like
but
methylpseudoaneurysm use, like a lot of
yes,
kinds
but
of drugs.
the most important is what initiates it.
The initiation is the atherosclerotic.
Yes,
Yes.
near the bifurcation of the aorta. But if the as you mentioned, there is a lot of causes. But the initial focus is this, which is important to say that it initiates near the aorta, so causing aortitis and the effect about the ureter. Another topic called radiation-induced aortitis. So it is radiation causing inflammation of the wall of the aorta and many things like thrombosis, stenosis, calcification in a late stage. Mainly we can think of it if we see a young that have calcification in the proximal coronary arteries and ascending aorta, and he is a young age. So we may think that he has mediastinal lymphoma treated and causing accelerated atherosclerosis of the wall of the aorta and cause calcification of the wall.
So what do we see here?
We can see calcification of the wall of the arch of the aorta and calcified anterior mediastinal mass, residual mass, and also here the calcification of the aorta and the calcified residual mass, which was anterior mediastinal lymphoma. And the important point is the radiation effect is only to the field of the radiation, not beyond it. So,
And usually when does it develop? How much after radiation? 2
10
weeks,
years.
2 days?
it can be يعني yearly, but usually after 10 years.
After a lot of years?
Yes, 10 years or more. Point about retroperitoneal fibrosis. We said that it's initiated at the bifurcation of the aorta and can extend to the IVC, ureters, and other viscera, but it doesn't displace our IVC and aorta anteriorly from the spine. So we will not see the aorta and IVC displaced from the spine due to the mass of the retroperitoneal fibrosis. So it tape it. يعني لصق يعني tape the aorta or IVC to the spine, not displaced it anteriorly. We finish non-infectious causes of aortitis and starting infectious causes, many causes like bacterial, viral, fungal. I choose 2 topics, syphilis and mycotic. Syphilitic aortic aneurysm, we know that syphilis is sexually transmitted disease. It's chronic. It has 4 stages: primary, secondary, early, late, latent, and tertiary. The tertiary one, which developed many years after the infection, include the heart and its vessels. Syphilis mainly affect ascending aorta and mainly cause aneurysm of the aorta. It can cause aortitis, can affect the valves, can affect even the coronary. But the special entity of it is the aneurysm. Here we have conventional angiography showing fusiform aneurysm of the ascending aorta and saccular aneurysm of the proximal descending aorta. So it can cause fusiform or saccular aneurysm. Of course, we should combine it with serology to diagnose it. Another topic is mycotic pseudoaneurysm. The name is misleading because it is not due to fungal infection. Mycotic means infection causing pseudoaneurysm to the vessels. But it is said that it is mycotic because who noticed a mushroom shape like aneurysm in the wall when he discovered it. So it is not due to fungal infection. It is not purely from the fungal infection. It's caused by infection, like salmonella, like any other infection. The important thing is it causes thickening of the wall. Maybe we can see gas in the wall of the aorta. Here, and ulceration. Here, this is CT angio showing the descending aorta having irregular lumen with ulceration, thickening of the wall, and even bubbles of gas in the wall of the aorta. You can see that the anatomical plane between the thickened wall and the esophagus is not clear. So it extends to the nearby aorta. Another CT angio showing the collection of the gas around the thickened aneurysmal abdominal aorta with irregular lumen and thickening of the wall. Here also the collection of the gas. So the important pathognomonic is the gas present in the wall, but we usually not see it, only in a few patients. هذه another lecture يعني ما خليتها هاي. Finish the lecture. If anyone have a question.
Good, thank you. Any questions, any comments?
By image, you can't differentiate between non-infectious and infectious.
No, we cannot differentiate just by image, but combined by image, clinical history, lab test, presentation, maybe multimodality imaging, مثلا إذا عندك CT, MRI, conventional angio of course. All of this can help guide us. Sometimes there are some specific features that might help. مثلا sparing of the posterior wall of the aorta, it goes with what? Inflammatory aneurysm. Okay. مثلا gas in the wall, it goes more with infectious and things like that. If you see the ureter is pulled medially, the aorta is taped to the spine, you can think of retroperitoneal fibrosis. Age again. مثلا إذا patient عنده mycocutaneous ulcers, which are where? Behcet disease, which are oral and genital. Okay? So you need, it's not like spot diagnosis. You need collection of data to approach a good differential diagnosis. Any question? Good.